So my second talk, and I promise I won't speak again, so you don't have to listen to me again, will be about measuring biomechanics pre and post cross-linking, basically evaluating the effect of our treatment. Before we speak about judging the change, we have to speak why it is important to stage the progression pre-op, because you will see that that will help us in evaluating the progression post-op. A staging and progression is important also because we cannot only use tomography to judge the change, because as we have seen, this is a biomechanical disease. And because if we use the CBI, as I explained you before, we designed the CBI to change very rapidly from 0.2, which is normal, to 0.91, which is abnormal. So, and that's the first take-home message. If you have a patient with CBI of 0.3, and then you see the patient back in 1 month, and it is 0.4, it's not a progression. It's just random measurement. So you have to use other things that I will show you now to judge progression. The same thing is for TBI and BED-D. They are not designed to judge progression. They are designed to judge normal versus abnormal. So why it is important, in addition to the ABCD, to have something else that will judge elasticity or biomechanics. So this is a study that in which we collaborated with Hamburg University. None of them is here, so they asked me to show this study in which I was a co-author. And they created a new value that is called E, A, B, C, D, E, which makes sense, and it's also elasticity, so it's easy to remember, and was somehow created with our work, because we have seen that the CBI was created with a logarithmic curve. But if you know a little bit of math, or if you remember a little bit of high school, you can change any curve to a straight line. So if you linearize the CBI, so instead of being a logarithmic curve, you create a linear version of the CBI, which is called CBI-F. Actually, the first time was published by Shizuka Ko, in which they called it CBI-beta, but it's pretty much the same thing, so it's a linear CBI. We have seen that actually the CBI linearized was very much correlated with the progression. So we didn't need to create anything new. So what they did in collaboration with us was to create stages with the linear version of the CBI that from now on we call it CBI-F. So the first step, it's this one, to create a linear version of the CBI. And then we have somehow to decide where are the gates, where are the stages. And as any staging in literature, it's a decision. So the Amsler-Krumai classification doesn't have a real reason for why these are the gates. Sometimes you have to make a decision, say this is 1, this is 2, this is 3, this is 4. So this is the publication. It's in Journal of Cataract Refractive Surgery. So this is the first publication. So what we did in collaboration with them was to judge, well, if the CBI-F is correlated with the progression of the disease, what is the term that is mostly correlated to it? Meaning, is the CBI-F correlated to thickness, to posterior radius of curvature, or to anterior radius of curvature? And we have seen that it was very, very much correlated with posterior radius of curvature. So we decided, well, if it is so much correlated, then we decide to make the gates based on B value, so posterior radius of curvature. But then you need another thing, because remember, every time you want to judge progression, you need to know the noise level of the system. And we cannot use the noise level of the ABCD, because now we need the noise level of the Corvis. And that was already done. That we already did a study together with Dresden University, Professor Reiskap and Robert Herber, in which we did repeatability. So we just needed to go back and take these results and use this 95% confidence interval to say, well, these are the stages, if it goes from this stage to this one, is significant. And this is how it works. So this is the commercially available device. Let's forget for one moment this part, because we will speak about it later. And let's concentrate on the right-hand side part. This is the E stage. And from now on, you forget the CBIF, and we go to the E stage, because the E stage is simply the CBIF in stages. Okay? So now we call it E stages. So you can select exams like you're used in the ABCD, so pretty much the same, up to 4 exams. So you cannot put many. We are up to 4 now. And you can judge whether there is a significant progression over time with the E stages, and this is pre-op. Now we go back to what I was telling you before. So why we need then the other parameters? For 2 reasons. First of all, because you never bin something that you know to work when you add something. So you remember, the ABCD is not like saying, well, we have the ABCD, then we don't use tangential map anymore. You just add something. And then because you need the single parameters to judge the cornea after cross-linking. And then I will tell you in a second how to use it. But I would like to just stop for 1 second to explain you what is a 95% confidence interval in simple words. Because sometimes if you don't like maths and stats like I do, we get a bit lost on the 95% confidence interval. It's very easy. I am 1 meter and 81 centimeter tall. So if you measure me down there, and I am 1 meter, 81 centimeters, and 3 millimeters tall, is there any of you that will say that I got taller from here to there? No. And you know that because you know the only possibility is that you made an error, just measuring. But we don't know that when a patient is coming 3 months later. So the only way to know is that you measure me here, standing 3 times, and you see what is the measurement error. The 95% confidence interval is this. So you get a 5% chance to say that I got taller and I was not taller. That's it. Very easy. So it says you have 95% chances to be right if you say that it's progressive. Okay? Well, I told you why the individual parameters are needed. This is a very interesting case that I will show you in a second. So this is a patient that was progressive. This is coming from Dresden University. As you can see, we have a lot of collaboration, which we thank so much, because this is how science works. This is a patient that was progressive in 2017. Okay, so remember this year, 2017. And then you go to the ABCD, and guess what? From 2017 to 2018, no change. Not even in the 80% confidence interval in any of the parameters. And what happens the year later? The patient is getting worse with tomography. So this is a case, it will not happen often, because most of the time things make sense with each other. So it gets worse with biomechanics, gets worse with tomography and everything. But sometimes you have a case like this that you can tell to the patient, well, you know what? Maybe I don't cross-link you with biomechanics because, you know, well, it's new. I don't know if I want to make a surgical decision based on that. But maybe I don't see you in a year. You know, I see you in 6 months. And then maybe you avoid seeing this tremendous progression because you want to see the patient in a year time. And then we go to judging the progression and the change after cross-linking. So we have few options: clinical outcomes, which take long time, and actually the patient gets worse in the first months. We have demarcation line, and we have biomechanics. So I'm going to speak for 1 second about what is demarcation line. I know that my friend Cosimo Mazzotta, that you will see a picture of him in a second, will have a full talk about biomechanics and demarcation line. But it's very important that you understand one thing. What do we know for sure about demarcation line? It is where the cross-linking arrives. So this is where you stop killing the keratocytes. But is it correlated with corneal biomechanics? The real answer is we don't know. Because Cosimo published this amazing paper in which he showed that the depth of the demarcation line in vivo, yeah, it's correlated with the stress strain ex vivo in porcine eyes, which is not the same. Pigs, human beings, in vivo, ex vivo, is not the same. It does make sense that the deeper you go, the more you stiffen the cornea, but we know from clinical practice that a patient with deep demarcation line will not get flutter for sure. Sometimes they do, sometimes they don't. And also we published that there is no association between the depth of the demarcation line and the change in corneal biomechanics measured with the Corvis. It might be that we were not able to be so sensitive to detect this association, but this is the fact. So far, the demarcation line is how deep you went, is not how much you stiffen the tissue. And that's the reason why you need to use both. So you cannot say, well, I have the demarcation line, I don't need the Corvis, or I have the Corvis, I don't need an OCT. You need both. And now we go to corneal biomechanics, and I'm going to speak about corneal biomechanics with air puff tonometry, because otherwise I speak for 2 hours and you don't want that. If you use air puff tonometry to judge biomechanics, you apply a force to a ball, namely the eyeball, and evaluate the response. This concept is correct, but if you change the pressure inside the eyeball, that's a problem, because a high pressurized ball will deform less and a low pressurized eyeball will deform more. So how do you disconnect these things? Pretty much you don't. So if there is a huge difference in pressure, it's almost impossible to detect what is biomechanics and what is eye pressure. Like with brilliant microscopy, that if the cornea is edematous, there is no way you can detect changes in biomechanics with corneal edema, because every single instrument will have drawbacks. There is not one perfect instrument. One problem of deformation technology is that if the pressure is completely different, it will cause problems. But that's unlikely to happen, because a patient pre and post cross-linking will have pretty much the same pressure unless has a steroid response, but that's time. You stop steroids and they go back, right? So what we have seen is that actually it's more important the shape rather than the amount of the deformation. A stiffer cornea, and I will go slow because this is complex, is slower in loading, has a smaller concavity, so the shape of the concavity is smaller, is faster in unloading, is less susceptible to deformation. This is the most easy to understand, but again is the one that will have more problems with IOP. Again, if IOP is compensated. So how do we do to measure biomechanics if we have all these problems? Well, we do it in clinical practice. First paper we published, we showed that we were able to demonstrate a change after corneal collagen cross-linking. That was the first time, because with ocular response analyzer, there are tons of papers pre and post cross-linking, and there are two that demonstrated a change. So, if you have tons of paper and only 2 are demonstrating the change, it means that that technology, it's not helping with this particular thing. The Corvis, there are tons of publications that are showing that you can see a consistent change, even long term. And I'm not going to speak about all publications, because again, otherwise I speak 2 hours. We have seen that there is no association with demarcation line, but a very interesting thing is that if you have a soft cornea pre-op, it's more likely to get stiffer post-op. If you say it like this, you say, well, it makes sense. It's soft pre-op, it will get stiffer post-op, but never was published before. How does it work in clinical practice? With the Homburg display, I showed you the confidence interval, so I will skip it. Simple words. Again, sorry, that's just repetition. That's the patient of before, cross-linked. This thing that you see on the right-hand side, you should not expect to see it. So the E stage does not change after cross-linking, because it's created to detect progression. Do not use something that was created to do 1 to do B because it will not work. Use instead this because it's created for this, to tell you it's stiffened. And the reason why well, at least we try, because sometimes even if you try very hard to say, well, don't use this index to judge progression, they do it anyway, like the bad D. We try to make it really foolproof in this algorithm, because if it's getting much better anyway, the software will not tell you that it's stiffer. It will tell you just there is no progression. I'm sure they will use it anyway in publications, but that's the most we could do. So that's a case report from Dresden again. Patient progressive with biomechanics, changing of Kmax, changing tangential map. You remember the one in 2017? We'll skip it because I showed you before. Tangential map after cross-linking gets worse, as we all know. And the patient comes to you with the parents, particularly because we all know that keratoconus patients, they have parents that they are very demanding. And they say, oh, why? It's getting worse, they don't see, blah, blah, blah. And you say, you know what? We know that actually we did the right thing and the cornea is stiffer. So we did exactly what we wanted. And we say, don't worry, we'll see you in 3 months, but we already know that your treatment is working. And in 6 months, the cornea is getting flatter. Is it correlated? The real answer is no. We did a study in which we wanted to see if there was a correlation between the stiffening effect and the flattening effect, and so far we are not able to see a correlation, unfortunately. We would love to, but it's not the case. This is an unusual case, again, unusual case just for leisure. This is a patient after cross-linking. See the change in E value. I've never seen anything like that before. So this is a patient that got incredibly flatter, like a lot. And it was so flatter, so stiffer, that the E stage went from E3 to E0 with cross-linking. You should not expect to see that. I use this example because you should not expect to see it. And now I use the last slides. I think I'm in time, right, Farad? No? Okay, 5 minutes. 5. To speak about the last toy, that is stiffness mapping. So stress strain index was created by Liverpool University. So I'm using their slides. It's a way to describe the whole stress strain curve, because the problem of the stress strain curve is that the E tangent varies with different loads. The loads is the IOP. So they tried to create a way to describe the whole stress strain curve not related to thickness and IOP. It looks like that they were able to do that because they demonstrated that it was not related to IOP, not related to thickness. Brill-1 and OCT elastography, they have many other advantages, like spatial resolution, depth resolution, blah, blah, blah. But they do not describe the whole stress strain curve because they are still related to the load. We will speak about that in the next days. But the Corvis is measuring only one line. So how do you get a map from the Corvis? You use tomography, and I will explain you, I hope, very quickly. So we know that stress strain changes in the cornea are related to distribution of collagen fibrils. This is easy to understand. Forget that thing. And we know for a healthy patient how fibrils are placed for X-ray measurement. We know that in healthy cases, the difference is pretty much nothing. It's very similar for everybody, less than 2% standard deviation, 3% standard deviation. In keratoconus, outside of the cone is similar to normal patient. So they created a method to describe cone morphology, very easy. Morphology is very easy to do. And then they used a method coming from X-ray in keratoconus cornea that were transplanted to estimate the fibril density reduction inside the area of the cone. So you have the morphology, you have the X-ray, and you say, well, this is the amount the fibril density was reduced based on the morphology. It's an estimation, so it's not perfect, it's an estimation. Then if you have that, what you can do is you can create a model for healthy eye, which is easy because you have pretty much everything, X-ray, you have morphology, blah, blah, blah. And then you have a model that is more complex, in which you use the morphology to estimate how much the fibrils were reduced in the area of the cone. So then you have two ways to have a stress-strain map based on tomography and one-line measurement of the Corvis. I hope I made it simple, because it's not simple at all. So this is a patient that with fibril density reduction overall in time with progression. Differential map that shows a clear change only in the area of the cone, which does make sense. Another patient. Another patient. So it does make sense. Doesn't always make sense, but most of the time it does. This is a population study with mean. You can see that it gets worse over time. So it does make sense. In progressive keratoconus, also the stress-strain index map does make sense. And I'm going to go with the last two slides, so Farad will not kill me. Finally, I can show you something about cross-linking. And the reason why it's so little is because this is another estimate. So we are not only estimating the fibril reduction, but we have to estimate only the amount of stiffness inside the cornea that is anisotropic, with one place that is completely different. So it looks like that with this preliminary estimation, we do have a change in fibril density, sorry, not in fibril density, in the cross-link amount inside the cornea. And it does make sense, because we do see changes in the area of the cone much more compared to the rest of the cornea. So this is example 1, and this is example 2. So future studies will help us to quantify the effect of UV fluence and time, and help us to customize cross-linking and decide whether we need to treat a patient differently in areas of the cone. Thank you very much.